It starts as small, painless swelling near your jawline, and suddenly you're being told it's cancer. But it's not just any cancer, it's rare, complex, and often misdiagnosed. Salivary gland cancers account for less than 5% of all head and neck cancers, but when they strike, they demand high precision, high stakes decision. Why? Because over 20 different histological subtypes exist, each with radically different behavior and treatment. It's evolving faster than ever with advances like IMRT, proton therapy, and molecular profiling. Let's decode one of the oncologist's most enigmatic threats. Salivary gland cancers are rare, making up only 0.3% of all malignancies and 3 to 5% of head and neck region. The most common sites is the parotid gland, approximately 80% of cases, followed by submandibular in 10 to 15%, and least affected sublingual. Interestingly, while 75% of parotid tumors are benign, malignancy risk increases in smaller glands. The World Health Organization recognized over 20 histological subtypes. The most common include mucoepidermoid carcinoma, adenoid cystic carcinoma, and acinic cell carcinoma. Each subtype has a distinct growth pattern and metastatic potential. For example, adenoid cystic carcinoma is infamous for spreading along the nerves and late distant metastasis, even decades after initial treatment. Diagnosis begins with imaging like MRI, which is preferred for perineal spread, while CT evaluates bone involvement. Exciting small tissue with FNAC aids in planning of treatment but has limitations in subtype classification. Core biopsy or intraoperative frozen section, that is, the removed cancer is tested in the middle of the surgery, even when the patient is still undergoing surgery, gives us more definitive report about the subtype. Surgery is the cornerstone for the treatment of removing the cancer along with involved nerves, bones, skin, etc. Facial nerve, which is responsible for our expression of face, is prioritized for preservation, but may be sacrificed in high-grade infiltrated tumors. Postoperative radiotherapy or chemotherapy is given as indicated. Recurrence rates range from 10% in low-grade tumors to over 50% in high-grade or inadequately removed tumors. Distant spread most commonly to lung and bone occurs in 30 to 40% of the cases. On the frontier, targeted therapy is under active investigation. For example, HER2 amplification, that is, human epidermal growth factor receptor 2, is a protein that plays a role in cell growth and repair. In salivary duct carcinoma, response to transumab, while androgen receptor positive tumors may benefit from anti-androgen therapy. Next generation sequencing, a DNA sequencing technology that allows for rapid and efficient sequencing of large amount of DNA and RNA is helping in personalized treatment protocols based on molecular profiling. Salivary gland cancers may be rare, but understanding their diversity is critical for survival. With evolving diagnostics and precision therapies, patients today have more tailored, effective options than ever. Don't let a small lump go unchecked. Early and expert intervention is everything. Got any questions? Drop them below and I'll personally reply to them. If you want to know more about head and neck cancers, comment below. I'll make a video on them. Thank you.